Well, thank you guys again for the opportunity to have this discussion. Today, or this afternoon rather, we'll be talking about a little bit about QI. This is a topic that used to make me scared. And so I'm hoping to dispel some of the QI business that I think really can be somewhat intimidating for pediatric cardiologists or any subspecialists for that matter. I have no relevant disclosures, but I do have a few disclaimers. I have no formal training in QI. I've never taken one course in QI for what it's worth. I have many friends though who do have formal training in QI. And so I've learned from a lot of my friends. And I am a public health physician who happens to be a pediatric cardiologist, my other disclaimer. And I'm a health disparities researcher, and most importantly, I will not be formally discussing run charts, key driver diagrams, and all of the things that people who formally have training in QI do, because I don't have that training. But I will talk to you about some of the applications I think in QI that we can use to improve the care of all patients. So the objectives for the talk today are to define quality improvement in academic pediatrics, to describe how data and creativity drive quality improvement initiatives, and to understand unique DEI applications of quality improvement in pediatrics. We'll start up here. So first, the question about what in the world is actual quality improvement. So see, these are things I think most people assume that we know. So quality improvement is a systematic, formal approach to the analysis of practice, performance, and efforts to improve performance. That's the formal definition. And so the QI process is grounded in some very basic concepts of establishing a culture of quality in your area, determining and prioritizing potential areas for improvement, collecting and analyzing data, communicating results, committing to ongoing evaluation, and probably the most important is then spreading your successes, so teaching other people what you've learned about. And so there are some very good examples of quality improvement over time in various sectors, some of which you guys might be familiar with here. So I think that some of the room will recognize what this is. I'm not sure that everyone will. This is called a Walkman. This is how we used to listen to music back in the 80s, for what it's worth. And that thing next to the Walkman is called a cassette tape. And so sometimes the cassette tape would get garbled and it would get warped, and then you would have to use a pencil to get the tape back in. Sometimes it would get eaten up by the Walkman. And now this is where we are, right? And so the quality improvement ahead that has happened in this space, and we're in a situation now where we can listen to music completely remotely, with Bluetooth in a different place, and it's pretty amazing. And branded, pretty well branded. I think everyone, if you look at that little case, everyone knows who is the maker of that case, right? And so it's impressive what has happened in quality improvement in other sectors. But what about in healthcare? What does it mean in the context of healthcare? So QI means the proper understanding and implementation of QI is essential and necessary for a well-functioning medical practice, any practice interested in improving any of the following: efficiency, patient safety, clinical outcomes, and then finally, patient satisfaction. We talk a lot about this in medicine. And so, actually, it turns out in pediatrics, there is a lot of work that we have done in QI as it pertains to kids and how kids are doing. So if you remember, not too long ago, kids used to sleep in places that look like this, right? Bumpers everywhere, blankets, stuffed animals, all over, sleeping on the side, sleeping on the stomach. And then there was data that showed that patients were dying of SIDS, and then there was a correlation between SIDS deaths and kids that were sleeping on their stomach, right? So they launched this very big back to sleep campaign, and it was taken very seriously at all of the levels, at the federal level, state level, local level, institutional level, and everyone was taught to talk about this with their patients. And so it was a uniform front for this. And so this is what we ended up seeing because of this QI effort. You saw that SIDS rates there across the x-axis in years, and the percentage of SIDS rates on the y-axis steadily decreased as the percentages of kids that were going back to sleep increased. Right? So this is a direct result of a QI initiative in pediatrics that was very, very effective because a lot of people bought into this. We had a lot of stakeholders that bought into this, and it was ended up being very effective. So on that topic then, how did we actually start doing quality improvement in healthcare? How did this actually begin as a field in the first place? I don't know if anyone is familiar with this publication. This is a publication that started in December of 1999. And it was published by the Institute of Medicine, called To Err is Human, Building a Safer Health System. And this publication really brought to light some of the issues that we were having in terms of patient safety across the board. It brought an awareness to the depth of the issue. And a lot of the reason that this came to light was because while patients were dying from motor vehicle accidents and breast cancer, and at the time, HIV as well, and AIDS, it turned out that when they did a deeper dive into who was dying in hospitals and what that looked like, there were more people that were dying of medical errors than of breast cancer, motor vehicle accidents, and AIDS combined. So that was a very big impetus for people to say, well, wait a second, we got to do something, right? And so this publication talked about identifying key stakeholders to do the following quality improvement. So getting all of these stakeholders involved were necessary for quality improvements across the board, including policymakers, administrators, medical students, residents, fellows, healthcare professionals, health journalists, and patient advocates, as well as patients. Because all of these patients together, all of these individuals together were required to move the health equity needle. So after that, they got into more about defining what the actual problem was. So beyond saying what is quality improvement and what does it mean, or what stakeholders, now we're talking about how do we define what is quality improvement, which problems should have quality improvement. So in 2001, 2 years after that initial publication, the Institute of Medicine published Crossing the Quality Chasm, which then outlined the systemic framework for measuring quality in terms of structure, process, and outcomes, and they specified 6 goals for quality improvement that could build more effective organizational structures. And those included redesigning the care process. Doesn't it feel like we're still there today? Using information technologies, managing knowledge and skills, coordinating care across patient conditions and settings over time, developing effective teams, and implementing performance and outcome measurement. So if you think about when this was proposed, and you think about where we are right now, I don't know about your institution, but my institution has a lot of these things now, right? They didn't used to have any of these things. And so that was where we started, was defining the problem and knowing what the problem was. And then as QI evolved, the next thing was focusing on how do we measure the problem. So one thing is to identify what the issue is. The next thing was to how to measure it. And the National Quality Forum established a performance measurement endorsement process and national performance measures that the Institute for Healthcare Improvement subsequently came out as a model, with a model for, specifically for QI in the healthcare setting. So we have all then heard of PDSA cycles, yes? And so that directly came from this publication. So this came from the IHI model for improvement of PDSA cycles. And they looked at 3 different process measurements, including structure measures, process measures, and outcome measures. And then balance measures in terms of how does one thing affect something else. If you try to improve it here, does that take something away from someone else? And so upon looking at this further, when you take a look back at To Err is Human, so the person who authored that actually wrote an op-ed on this in 2019 about how have we done it over the 20 years since the first publication was done. Have we made any major changes? Have we moved the needle in the QI space in healthcare? And the report said that while it was successful in raising awareness of how serious the scope was in terms of QI issues and the magnitude that we needed to undertake for the nation's healthcare quality and safety, that we had not then moved the quality and safety needle as much as we had hoped to, and that this whole approaching this with a one project at a time, with quality professionals applying a one-size-fits-all, was not maybe the best way to do this, because there are different disease processes, there are different structures that hospitals have, different resources that hospitals have. So that made that more challenging. It also resulted in improvements that have been modest, difficult to sustain, and even more difficult to spread. Because I don't know if you know this, but we work in silos in academic medicine. And so trying to get this across to other places and to talk amongst ourselves is very challenging. And it shifted the improvement paradigm in 3 important ways, or he thinks that we need to shift the improvement paradigm in 3 important ways. That committing to zero harm is critically important, that overhauling the organizational culture is critically important, and that adopting the most highly effective process improvement methods is really important. So zero harm means 0 complications for patients, 0 injuries to caregivers, 0 missed opportunities to provide effective care. Then that's not easy to do. It may take another 20 years to get to that place. And so other industries have done it. Commercial aviation industries have done this. Nuclear power industries have done this. And so it's possible because they've accepted nothing less than zero harm in those industries. And so I think that Dr. Cazden has said that we need to do this in medicine as well. In order to do that, of course, it requires a lot of money and dedication from healthcare leaders and organizations for this. So as I thought a lot about where we started with QI and where we are going to and where we are now, I really thought about the way that we think about QI. So I remember in fellowship and in residency, whenever I would hear QI, I'd be like, CLAPSI. It was like a major. And I remember, and actually I have to tell you, I'm very proud of this. We just got an email yesterday from Texas Children saying that our cardiac ICU has had 0 CLAPSIs in the last 1 year. 1 year anniversary. We're like, oh my God. So it was very exciting. But that's the one thing that I knew about QI was CLAPSIs, the end. And so that's great. But it's really important to think about how QI doesn't have to only be that. And you don't have to be formally trained in QI to make a difference in QI. So what if we thought about QI not as a series of PDSA cycles that people usually force us to think about, and flow charts and things like that, and we thought, okay, what are the things that we can do on a daily basis to change outcomes for kids? And we call that quality improvement. So what if we looked at things differently and we understood QI to be a part of the research that we do, a part of the populations that we serve, the advocacy that we do, that contributes to moving the needle for access to care and care delivery and patient satisfaction and clinical outcomes, but looks at it in a less traditional way, and not the PDSA cycle way, and not the way that it has to be done. Because there are ways to do QI that's not perfect, but at least it helps to move the needle. And so rethinking areas for quality improvement in pediatrics, when you think about that, what are some of the areas that we could think about QI that have to do more than just CLAPSI? So what if we focused on QI beyond these CLAPSI rates, and we thought about collaboration to drive QI? So working with different, not only different places within medicine, but within different sectors. What if we partnered with law to move QI? What if we measured social determinants of health in all patients to improve outcomes and said that that was QI? Or if we focus on QI and lifelong care and the growing population of youth, because you spend so much money up front, and then they get 18 or 21 depending on the state you're in, and we say, sorry, and good luck to you. What if we focus on QI ways to actually not just identify social determinants of health, but to address them as ways to improve care? And use QI metrics for DEI initiatives. So as I think about QI, I usually think about maybe being less formal about it, and this is no shade to my QI colleagues, okay? Those people do a very good job, they're amazing, and they're very detail oriented, and God bless them, because we need them. But there's other ways to think about QI. And so let's talk a little bit about how data and creativity can drive some of these quality improvement initiatives in the various fields. And so I'm going to start with a little bit of a story about COVID-19, because it's something that we all experienced, and I think it has a lot to do with understanding QI and in pediatrics. So, when COVID-19, when we first started hearing about it, what you heard, if you remember this, was, okay, in Asia and in Europe, people that were getting COVID-19 were older, right? They were male. And they had pre-existing conditions, like they had all been smokers. So that's a lot of what we heard, right? You didn't hear anything about younger people or people that didn't have pre-existing conditions. And then in the United States, a story started to unfold, as you know, in the epicenter in New York, right? When people started saying, oh, what is this that's happening in terms of COVID-19? And the doctors started saying, it's really funny. I'm not saying what they're saying in Europe and in Asia. I'm actually seeing younger patients. And a lot of the patients that I'm seeing are from communities of color, and I'm seeing sometimes I'm seeing kids, and I'm seeing a lot of women. So I'm not sure what is so different about this than it was in Europe, but it does not look like what it was looking like in Europe. And so people started asking questions, and Abraham Kendi, I don't know if you guys know this guy, but he's the famous author of How to Be an Anti-Racist. He started asking questions in op-eds, asking how come we don't know who the coronavirus victims are in the United States? Why is that? Like, they seem to know who it is in Europe. We don't seem to know who it is here. Why is that? And so when he started looking around, sure enough, he was right. We didn't know who they were. So the CDC, Prevention Information Site, didn't offer any data on patients by race and ethnicity or by SES, or socioeconomic status, was getting COVID. Neither did the Hopkins University website, CNN, no. The New York Times count, no. The COVID Tracking Project, no. And so we had very little information about what the actual population looked like that was getting COVID. We just knew that a lot of people were getting it, right? And so the first state to actually release information on COVID by race and ethnicity and to some degree socioeconomic status was my own great state of Illinois that I'm from. The Illinois Department of Public Health became one of the few states that released some racial data, and their data showed that there was a pandemic within a pandemic. And so that African Americans were significantly overrepresented in the infection rates in Illinois, while whites and Latinos were significantly underrepresented. And so while African Americans made up about 14% of the state population, they made up double of that, 28% of the confirmed cases of COVID. And so when people started asking the CDC, like, hey, this is really alarming information, and we're not even getting it from New York, we're getting it from Illinois, can you please tell us information? We need to know who's getting this so we can figure out how to come up with strategies to mitigate this for populations. And the CDC officially said, well, you know what, the states and local authorities have been overwhelmed by the volume of cases, so they lack the resources to fully investigate the characteristics of all individuals, and because we don't have full data, we can't give you the data because it's only partial data, so we can't give you any of the data. And so the reason that we learned anything about the race, ethnicity, and socioeconomic status of the patients who ended up getting COVID during this pandemic is because the New York Times filed a Freedom of Information Act lawsuit against the CDC to force them to release the information that they had in order to get data on the COVID patients and what the patients look like. And that resulted in this first publication here in the New York Times of the fullest look of racial inequity of coronavirus. And you can see there in the bar graphs that the people who were losing the most were Latinos, in terms of the highest percentage of people that were getting COVID, followed shortly thereafter by African Americans. They didn't even have data for Native Americans for sure, but that was at least a start. And it was one of the things that really was alarming because this looked super different than it did in Europe and in Asia. And so, they found that Black and Latinos were disproportionately impacted by the coronavirus in a widespread manner that spanned various ages, that spanned rural, urban, suburban. It was any individual that seemed to be from these particular groups. And so when we were left with the question of why this is, we kind of covered this morning, it was directly due to systemic racism. Because these are the patients who could not socially distance. These are the patients who lived like several people in one home, that were essential workers, that either didn't have insurance or they had bad insurance that didn't allow them to receive care with enough time to get care, or at least the care that was required for COVID-19. And so if you can imagine that the data was lacking for adults, then the data was certainly lacking for children. So for whatever little data we have for adults, we had even less for kids, right, when it came to COVID-19. And so there was only one state that was reporting who was getting tested for COVID-19 by age, and that was Illinois. There was a couple states that were saying who was getting COVID in terms of kids, and that was California and Illinois. Michigan said, sure, you can have this data, but here's this complicated Excel spreadsheet, good luck to you. And so that was very challenging. And so it turned out that the CDC, the states that actually reported to the CDC after people started reporting, it's not mandatory reporting, right? This is just voluntary. And so for these pediatric hospitals, which you remember, in the beginning of the pandemic, adult hospitals got the CARES Act funding and pediatric hospitals did not. They really didn't have the bandwidth to do this. So only about 45% of the cases, or 50% of the cases or so, had race and ethnicity, but the rest of it was just missing data, which was less helpful. That was also then true for who was getting hospitalized. There were no states that were reporting hospitalizations for racial and ethnic kids by age. I can tell you that this is still true in Texas. They refused to report by who's getting hospitalized. There was zero data on children in Texas. And so they also, the CDC didn't have a very, efficient way of talking about who's getting hospitalized. And the DHHS, the Department of Health and Human Services, also had no race and ethnicity data for this. And so, even more so, who was getting admitted to intensive care units? There was only 2 states that were reporting admissions based on COVID, and that was Minnesota and Wisconsin. And no states were reporting this by race in the state. It was just kind of like these kids are getting admitted with COVID or COVID adjacent, and that was about it. So in a creative QI solution, the PICUs, to their credit in America, said, well, this is ridiculous, and we need to figure out a way to know who is getting sick if you're a kid and what they look like so we can help them and try to predict who's going to come in and give some public service announcements about what to do or who's most impacted or affected. And so the PICUs actually put together a dashboard on their voluntary dashboard of all of the patients. And they had race and ethnicity reported for about 96% of patients, which is extremely impressive because this was a voluntary effort that they did on their own. And you can see that that's the website that they used to track their data across all of the PICUs. And so this is all, again, all voluntary, the PICUs across America. And what they found, no shock, was very similar to what you see in the adult spaces. That Latinos had the highest percentages of kids that were getting admitted to the ICUs with COVID. Followed by African Americans and Caucasian populations. And while you look at it, you say, oh, see, blacks and whites were equal. Well, it turns out that you don't factor in the denominator when you're looking at that, right? So if you think about the denominator of patients that are black in America versus white, there's still a much higher proportion of blacks than whites that are actually being admitted to the ICU. And so it was really impressive that they pulled this together. And this was a QI initiative that didn't really do PDSA cycles, right? Didn't have time for that. Nobody had time for that in this pandemic. And so this just required people to have creativity and initiative to say, I want to impact our populations that we're serving. And how can we do that? Well, we're going to have to do it ourselves and get this data together and really help the kids. And so as we talked about this morning, a lot of what we learned in terms of the social determinants of health was that is what was driving the differences in outcomes. It wasn't somebody's race or ethnicity. It was the fact that these individuals had been historically disenfranchised and had suffered from systemic racism that put them in worse categories and gave them higher risks because of the social determinants of health in terms of their outcomes, right? We talked about redlining this morning, and again, not coincidental that the same people who live in those areas were the ones who were presenting late to the hospital, were the ones who didn't have access to care, were the ones who had pre-existing conditions of diabetes, of hypertension. These are all the same people, right? And so this bears repeating. We talked about this morning, but I want to mention again, it is important to recognize then that race is a social construct, right? So we've talked about this before, and we need to be able to use race when we're using it to explain these social experiences and resulting from things like the social determinants of health or inequalities in the social determinants, and not biological facts to explain what we're seeing. So a lot of times people said, oh, it must be that blacks are predisposed to getting COVID. No, it had to do with the fact that they were the people who had the higher risks because of the situations they were in, right? And we also need to provide a more thorough interpretation of the results beyond just somebody's race that we talked about this morning. So we discussed that systemic inequities stem from racism this morning, right? We talked about the different forms of racism, the structural racism, the institutional racism, and then of course there's the interpersonal and the internalized. And this morning we talked about redlining and how the practices of redlining are things that put people at a different disadvantage. That was in the housing sector. But of course, systemic inequities stemming from racism impact all of these sectors, including healthcare. And so if you think about what else is impacted, we can give other examples in other sectors. So here in Oregon, blacks from Oregon are imprisoned at a rate that is 4 times that of white people in the state for the exact same crimes. This is not for worse crimes, but for the exact same crimes now. A lot of that has to do with some of the policies that are put into place for how these individuals are prosecuted. And then in 2019, there was an audit that was done about the deep racial disparities in student achievement in the Portland public schools. And they found that when kids live in poverty, that their daily worries become more focused on survival, and that education is lovely, but that takes a back seat to things like, I have no food, right? And so this report was really alarming. I mean, this is just put out like 2 or 3 years ago. It showed that 21% of black students met or exceeded grade level standards in 2017, compared to 74% of white students. And that black achievement level differences for math are even steeper. Only 11% of black students met that standard for math compared to 60% of white students. And so, again, a lot of these things are rooted in some of these institutional racism, structural racism that we talked about. And another thing that the students said, the report said, is that the lack of teacher representation, so having no teachers that look like you to teach you about these topics, were partly to blame in terms of these discriminatory practices. in this county for communities of color. And students have demanded change over and over, but often their social status determines the quality of their education and their access to resources, which we also see in the housing sector. So when we think about making change at this level, at the systemic level, the only way that we're going to win is by collaborating with other individuals in different sectors. The only way that we're going to make an impact and say, listen to all of us, not just some of us, that are screaming here in the healthcare sector. It's important. So to that end, I am fortunate enough to be able to collaborate with brilliant people over at Rice University who are sociologists, who are experts in neighborhood level factors that impact health. And they said, hey, you know what, you're a pediatrician, you know about PD stuff, so why don't we join forces and I'll look at the neighborhood level stuff and you look at the health outcome stuff and we can come up with a comprehensive solution, or at least a picture of what this looks like. So we did a study on kids that were 2 to 12 years old and included each child's record and geocoded those records based on physical resident address. And so we linked that to the census tract and neighborhood level data, as well as social and economic indicators from the census files that were from the American Community Survey data. So it takes several, these are people who can just meld these things together, because I can tell you that I'm not an expert enough to do these things, but epidemiologists and sociologists are, and that's key to be able to do this work. And so we looked at a lot of the air quality data. So then we also brought in the Texas Commission on Environmental Quality Air Monitoring Information stuff to look and see what does asthma look like depending on the neighborhood that you live in, and what do the outcomes look like, and how do patients do depending on where you live. And no surprise, we found that there was a significantly higher proportion of African Americans and Latinos that were living in disadvantaged neighborhoods. No surprise that those disadvantaged neighborhoods had worse air quality, right? And that affluent children in middle class and advantaged neighborhoods experienced significantly lower levels of these particulates in the air relative to disadvantaged communities. That may not look like a lot of numbers, those little 10.24 and 10.45, but those numbers actually are huge in environmental science. I had to part with environmentalists to be able to understand this work. But looking at that says to us, it's not just that the kids have worse asthma because they are Black. It's actually because of the neighborhoods that they live in that allow for higher levels of pollution. And now kids that have asthma are exposed to this environmental milieu and are coming to their ERs a lot more often. And so having this data, and then having people like Dr. Rachel Levine, who's now doing some of this environmental justice work, together to be able to, having this data is the only thing that's going to move that needle, because unless we have the data, people aren't going to know how these things are linked, right? So we've also done some collaborations to improve the quality of data in terms of how patients do, and so I alluded to this morning. So now I can actually show you with the map. So this is a map of Houston. You can see there that the red areas are the areas in Houston that have the highest amount of pollution, the highest amount of toxins in the areas. And this area here that is circled is the area that I talked about earlier this morning, which is the 5th Ward of Houston. And you can see that it's in red, so it has the highest amount of toxins and pollutants in that neighborhood. Okay, so we were just showing the areas here, and so that and we talked about how the highest concentrations of individuals that were living in those areas were, in fact, African American and Latino. And then we talked about how people who live in those areas, where the kids that live in those areas, had a 5 times higher rate of getting cancer compared to any other place in Houston. And so what's even more alarming is that we actually knew about the higher cancer rates in this area because we had data about the adults in that area in 2019. We had data about the adults in that area were getting greater than expected incidences of adult cancers in lung, esophageal, and throat cancer. Yet here we were a couple years later looking at kids and saying, oh my gosh, they have higher rates of cancer too. Well, it's not a surprise considering what we knew about the adults living in those areas. So when we think about quality data that drives policy, because of some of the work that individuals have done in this space between health and the environment, that is what led to Biden's administration promising to address environmental racism. And this is actually an initiative that his entire administration has to try to get at what happened as a direct result of some of these racist policies back in the day, and trying to rectify them now and make them, make right with them now. So a lot of times when we talk about this, people get overwhelmed and they're like, oh my word, like, listen, I'm not an environmentalist, I just can't even handle like my notes at night, what are you talking about? And so it turns out that there are actually things that you can do to help in terms of QI projects to work for this. And so I wanted to bring up a project that we had done as a QI project to address social determinants of health in a subspecialty population and actually across all subspecialty populations. And so we got a grant, and I'm working alongside some very brilliant physicians at Texas Children's, Dr. Jean Raphael, who's an academic pediatrician, Dr. Michelle Lopez, who's a hospitalist, and Dr. Claire Bikini, who is an infectious disease specialist. None of us work in the same space, but we all have kind of a passion to doing interventions to improve the social determinants for patients. And so this grant was trying to find ways to identify food insecurity for our patients and saying, based on this, what can we do to intervene and make things better? So I want to emphasize, I am a pediatric cardiologist who's talking about food insecurity now, because guess what? It impacts our patients too, right? And so and this is a thing that we took over during the pandemic. So we really knew that it was pretty major during that time. And so we worked with Epic. Did you hear that? We worked with and the Texas Children's Health Plan. And so that's our plan that works with Medicaid. It's our own Medicaid health plan. And the Houston Food Bank to see what could we do to improve food insecurity for patients. And we worked with the Texas Children's Health Plan community health workers. So they actually employ community health workers there to do a variety of different jobs. And we said, cool, can we teach them to do this job too? And so we did not put the onus on the doctors, okay, to screen for food insecurity. That's unrealistic. We said, doctors care about this too, and we want to help our patients, but we don't know the best way to do this. Let's try this. And so as a result of this, we worked together with the Center for Child Health Advocacy and Policy. These are all the docs that I was talking about, as well as a resident and medical student. And we said, hey, Houston Food Bank, we're going to start sending you referrals for patients who flag positive for food insecurity that were identified by the community health worker. We taught the community health worker how to screen for food insecurity, so she knew what to do. And now we're going to move forward and see how this works. Well, in fact, it was so successful that we broke the Houston Food Bank. They had to employ more people for the volume of patients that we were sending them, because we sent them so many patients, and they said, oh my God, we are broken, we need to hire more people. And so that was, for us, that was pretty amazing. And we actually did a really mini randomized controlled trial. We said, what happens if we give you guys the number of patients versus having the Houston Food Bank reach out to you? And we looked at what happened in two different arms, and no surprise, the people who got the number said, that's cool, this is just another thing to do on my 80,000 things of list of things to do. And the majority of those patients didn't call. But for the ones that the Houston Food Bank reached out to, 89% of the patients were like, yes, please, I need some help. And so small, this is a small scale thing, but it of course crossed all subspecialty populations, and you can imagine that within our population, some of these patients are the ones who needed the most help. They're the ones who actually are some of the most disenfranchised populations. And it was really amazing to see how this little initiative was so successful with our community partner. We could not do this alone. We could not give the food ourselves. Nobody's sitting there collecting cans at the Children's Hospital. So this was something that required a community partnership to be able to work. So what about quality improvement and lifelong care? Now this is something that's near and dear to my heart, which is why people always ask me if I'm an adult dental specialist. I am not an adult dental specialist. I'm a pediatric cardiologist who tends to like teenagers a lot. And so I like to help them become successful adults. But without the data from Canada that came out in terms of how many adults that we had with congenital heart disease, we would probably never have some of the stuff that we have going on now in ACHD, right? So this is a study that was done in 2014 looking at people that were surviving with congenital heart disease, and this was the first publication that showed that there were more adults living with congenital heart disease than kids. It was the first time we actually heard this data. And so we knew that we actually had to now do something to help adults because they were surviving. And that was not just true for all CHD patients, but it was also true for those with severe CHD. So without this data, how could we embark on a quality improvement project? Because we didn't even know that one needed to be done because we didn't know how many of the patients were existing or surviving. And so the same thing was then true for neurodevelopment, right? So at first we were like, we are so awesome because everyone is surviving, yay us, yeah. And then we realized that they were surviving and not thriving, right? So suddenly the recognition came that like, oh, that's weird. How come some of these kids are like repeating fifth grade? What? And recognizing that while they were surviving, the thriving part of this was an issue. And then this study came out in 2017 that said for those individuals that had more severe CHD, that their neurodevelopmental outcomes were worse. The percentage of patients with impairments was pretty high, especially if you had severe disease. And that, of course, that data led to what we now know as the cardiac neurodevelopmental outcomes program that most large centers have, right? So without that data, without someone investigating what needs to be improved upon, without the research for that, we wouldn't even know that we needed this. That we needed to have programs that looked at flagging motor delays and language delays to be able to help patients do their best as they got to be older. And now, of course, we're increasingly recognizing things like mental health disparities, right? And we're recognizing executive functioning disparities. And that was all directly due to the work that people have done in the research space to drive QI. Because you don't know what you need to do until you have the data. And so if we thinking about that topic then, if we think about all of these adults that have become, all of these kids that have become adults with congenital heart disease, can anybody here tell me what is the formal training that adult cardiologists have to have in congenital heart disease by the time they're done with their adult cardiology training? Straight up adult cardiologists. Zero. Zero. However, there is a suggestion of 6 hours of formal lecture that you should have. But you're right. There is zero requirements for training for congenital heart disease in adult cardiology. That ends up being a problem because if you look at the numbers of patients that are becoming adults, which is estimated to be about 40,000 a year that have congenital heart disease,
Wow.
based on then the numbers that of ACHD doctors that are graduating, well, this is a math problem that we have now, right?
Yeah.
And so this is actually old data because they keep the adult cardiologists have board certification every year, which I think we can be clear that we do not have it in pediatrics. But so they have about 38,000 now. About 38,000 adult cardiologists that have board certification compared to the whopping 468 in adult congenital heart disease. Okay. And that's problematic for several reasons, one of which is the compensation for adult congenital heart disease doctors is not even close to that of an adult cardiologist, despite the numbers of years of training that they have. And so for every one ACHD doctor, there's at least 4,500 patients that have congenital heart disease that need to be serviced, okay? And this is a math problem that we have. So now that we have this data, we need to figure out ways to improve the quality of care for these patients and find ways to partner with our adult cardiology colleagues. Because let's be honest, any guesses of how many graduates in ACHD were last year in America?
15?
15? Someone said 30?
Yeah.
7.
Unicorn. 15
So good for you for job security, but this is a problem.
Underpaid job security.
Yeah, underpaid job security, that's right. And so, this ends up being a big problem for everyone across the board. And so figuring out ways to partner with our adult cardiology colleagues to help us deliver care, or at least triage these patients and require some sort of training is probably going to be pretty important moving forward. Well, what about the social determinants of health? We talked a little about that this morning in terms of how it can mediate some of the outcomes. This is a publication that came out in October 2020 asking the question, social determinants of health in terms of outcomes, what levels of care of cardiology does it impact? Does it impact fetals? Does it impact kids, infants, teenagers, adults? What area, ICU, outpatient, what does it actually impact in terms of outcomes? And the answer is everything. It impacts everything from prenatal diagnosis like we discussed this morning to having increased loss to follow-up, lower performance on IQs, word cognition, ACHD, endocarditis, you name it. The outcomes are worse based on inequities and social determinants of health across the board in pediatric cardiology and in adult cardiology. And so when we were thinking about some of this, we were asking the question then, okay, well, if we know that there's very little adult cardiologists and we know that the ACHE population is at a higher risk because of the social determinants. What does their access to care look like? Well, we don't know where they live because we don't have a national registry of ACHE patients here, right? So all we can do is take a guesstimate and extrapolate from the Canadian data, which we do a lot, to figure out like how many there are here and then where they might be living to make our assumptions, our models. So I worked with a brilliant pediatric cardiology fellow. So for the fellows room, this was a fellow project, okay? Dr. Katie Salcioli, who is now an ACHE doctor at Texas Children's. And we looked at models for geographic and sociodemographic access to care disparities for adults with congenital heart disease. And so, again, we partnered with epidemiologists and GIS specialists to say, okay, can you help us if we can give you the general population breakdown and assuming that pediatric adult patients live in the same kind of distribution as pediatric patients do, can you help us figure out what does access to care look like for these ACHE, accredited ACHE centers that exist in the United States? And so we used the website, the Adult Congenital Heart Association website, and we looked for specific centers and where they were. And then we put a map of the United States on there, looking at drive times from various areas to those centers and the demographics within those areas and what did access to care look like for those centers. And you can see there that the green is the actual CHD centers, ACHD centers. And then the darkest blue is the shortest driving time, less than an hour. And then the darkest gray is the longest driving time of more than 6 hours. So more than 6 hours usually means you have to take like a day, sleep over somewhere for your care, which I know is not common here as well. And so what we found, no surprise, was that the patients that had the least amount of access to care were those that had no insurance, those that had Medicaid insurance, those that were Latino, those that had less education. And again, we merged a lot of the census tract data to get at this, to say what does the access to care probably look like, because we don't have official data, which is another issue. But this helped us kind of understand that there is disparities in terms of accessing care for ACHD populations, because a lot of times our patients who, particularly those that have not been transitioned appropriately, think, oh, it's cardiology, so this cardiologist can take care of me, and they don't realize that adult cardiologists are not trained to take care of them, especially the ones with severe disease. We talked about the Affordable Care Act this morning as well, and how that eliminates health disparities, right? That was the answer to everything, and it turned out that in fact it wasn't. And so that same pediatric cardiology fellow, Dr. Salcioli, worked with me on this project. We used the National Inpatient Service database, and we looked at who was getting care at hospitals across the ACA periods of time, and what that looked like in terms of breakdowns of patients based on race and ethnicity. And no surprise that once again, Latinos and Blacks were the most uninsured or underinsured populations compared to non-Hispanic whites. And that then obviously tells you that the Affordable Care Act, while it has been helpful in getting patients insured, it is not the end-all be-all. And I can tell you that at Texas Children's, you guys know that the marketplace insurance, there's various types of marketplace insurance, right, Affordable Care Act insurance. And we went from accepting all of them to accepting one. So I lost a large number of my patients because they could not be on that one program because it was too expensive or whatever it was. But because the hospital said we just can't afford to partner with the federal government on these, well, what can we do? We can't afford it. And they're asking us for rates that we can't afford. And so it was very also confusing to the federal government that adults were being treated at pediatric centers. They were like, what? What are you talking about? That is also a nuance that was very unclear to them. And I think it's important to recognize that this is part of the reason why having doctors' voices with lawmakers is important, because they don't get why adult congenital heart disease patients are better served, at least surgically, at pediatric centers, like we already know, right? This is further exacerbated by the fact that if you think about those that are uninsured and those that are unemployed, if you look at unemployment by race in America, especially during the pandemic, individuals that were the most unemployed were Latinos during the pandemic, and followed by African Americans. And so if you're compounding a already challenging access to care issue with now further unemployment issues by race and ethnicity, well, now we have a real problem in terms of accessing care. And so working with several amazing docs that work in the transition space, we were able to publish this AHA scientific statement on how to manage transition for patients with heart disease and some of the practical approaches to making a transition program. And in that publication, we talked directly about how the social determinants of health impact transition. So it's specific to transition. This is how the social determinants of health can impact poor transfer of care, poor transitions of care, et cetera. So as a result of my own clinical frustration, every time I've interacted with the adolescents who knew nothing about their heart disease, and then furthermore having their parent answer all the questions, I lobbied to create a transition program at Texas Children's. We put together a business plan to speak to the bottom line of the institution. We said we still need to make money, which is fair. And then we put together a proposal to say, this is how we can actually still make you money. If we can increase the retention in the ACT patients at Texas Children's, then we can bring in more patients on the pediatric end, because we'll be transferring them to adult heart disease care. So it actually makes good business sense for you to listen to us. They were like, okay, we'll give you a year, good luck. And we were like, oh my God. So we hired a transition nurse and a social worker, licensed clinical social worker. And now we have the benefit of having a clinical psychologist as well to help us in this space. And so we launched a formal program in 2016. It is a team that while I'm the medical director, they have the team, they're boots on the ground, these individuals. And so they are the ones who see all of the patients for all of the doctors. They do transition programming for all of the doctors. So the doctors aren't doing it because that's crazy talk. And this team is doing it because the doctors don't have time to do it. And so they do all of the talks about sex, drugs, and rock and roll. That first of all, the cardiologists were like, please don't make me do that. And they do a lot of the talking about even career counseling. We had a guy who had an ICD, and his dream was to be a welder. And so we said, so that's probably a bad idea. And so we talked to the cardiologist and said, hey, listen, we talked to him about this. So the cardiologist was like, what are you doing talking to people about their job? And I'm like, we have to do this because he cannot do this job. And if we don't talk to them about what's possible, then what are we doing? Because we're the ones who know, right? The pediatrician's not gonna know. And so it was critically important for us to kind of talk to our, service care team across the board. That includes MAs, nurses, cardiologists, et cetera, to say if we're going to deliver this program, we have to do it in a way that all stakeholders are involved, that all stakeholders are bought in, because without all stakeholders being bought in, this is not going to work. You have to be bought into the concept that transition matters, and this is why it matters, because it improves outcomes. And so our program looks like this. So we start at 14 years of age. That's where we introduce the program. So we have done several unofficial PDSA cycles on this program. Well, we learned that if we start to do transition without introducing the program first, that goes poorly. And then if you just do a one-time, one-size-fits-all, that goes poorly. And so we do individualized learning plan for each patient. We do serial education visits. On average, patients get at least 3 visits. We do motivational interviewing, because without that, patients don't tend to lie on their surveys, because they're teenagers and they know everything, right? And then we talk about supportive, decision-making, shared decision-making, and healthcare changes that happen when we turn 18. And so we started talking to parents too. And then we do finally, at 18 to 21, we do an adult planning visit. An adult planning visit is a visit that is an hour long, which you can bill for both half hours, by the way. I never thought I'd know this much about billing, but anyway. And so part of that visit is for the standard established care visit with the patient. The other part of that visit is for advanced directives discussions. So it turns out that if you transfer a patient to adult care and someone says to you that you've never met before, have someone talk to you about your death, any chance? That does not go well. And that also undermines the trust that the patient might have with a new provider. So if we do it on the pediatric end for the person that they've been seeing forever, that tends to go much better. And so we do advanced directives in that final visit. We do their transfer summary in that final visit so that they have an official document. We also then require the pediatric cardiologist to identify by name an adult general provider, because one of the primary predictors to having poor transfer of care is not having an identified provider taking care of you. And so if you don't have an identified ACHD doctor, then patients are kind of like, I don't know if this is sanctioned by my pediatric cardiologist. And so that doesn't go as well. And then furthermore, we do have them have a visit with the adult heart disease team 3 months after they leave pediatric care. Because other data has shown that another primary predictor for poor transfer of care is if there's a long distance between your pediatric care and your adult care. And so we collect all of our data in REDCap, because without that we don't have enough data. And all of that data is collected in our REDCap. And this is our chat tool that I talked to you about earlier. This is the heart health activation tool, where we have red, yellow, and green that we are able to teach patients. So in our program, parents were like, that is so cool that you're teaching my kid. Also, I know nothing. Thank you for that, since we were like, oh, oops. And so we learned that parents need as much of a transition as the kids do. I mean, these poor people have been advocating for the kids since they were born. And now suddenly we're like, hi, you're not a part of the equation. They're like, what? So you have to prepare the parents too. And so we have done workshops with parents where we introduce them to the ACHD team, where we introduce them to the concept of transition so they understand what's important. So upon looking at this, we have done now a formal evaluation of our transition program. We just presented this at the AAP in October. And we looked at changes in knowledge, changes in skills, and patient retention. We also looked at levels of engagement, stage of change, but that's very psych, and I'm not going to put you through that today. But suffice it to say that has also made a difference. Our program's made a difference. So when you look at the outcomes from our program, it turns out that independent of age, so no matter what age group, you can see that the ages are in the different boxes. They're 14, 15, 16. On the x-axis is the number of transition visits, and on the y-axis is the patient's knowledge, with 0 being no knowledge and 3 being a lot of knowledge. What we have found is that independent of age, if you're in our program, your knowledge increases independent of age. So I don't care if you start at 16, 17, it still increases if you participate in our program. The same thing is then true for the Q skills, the transition skills. So if you participate in our program, over time, you can see that with each successive visit, that their transition skills increases as well, because of course it does, because we're teaching them these skills. So part of the problem with transition is people don't know what they're supposed to know to be adults. I mean, for those of us that didn't grow up with a chronic disease, we didn't know we were supposed to know as adults, right? So you can imagine what that looks like for a chronic disease patient. And probably the most telling of our stuff is patient retention. And so for patient retention, we looked to see what the patient retention was before our program was instated, and then during the period that our program was instated, at satellites that don't receive our program, and then what did it look like at the main campus in terms of retaining patients. And to be fair, we only looked at patients at Texas Children's. We didn't look at patients, like what happened if you left Texas Children's, because we don't have that data. We just looked at the patients who stayed at TCH. So what we found is that prior to our program initiation, our patient retention rate was about 28%, which is pretty standard if you look at across the board at the literature. And then at the satellite clinics where we don't have a transition program, that same period of time, the same period of time that we initiated our program, about 29% of the patients were retained, so very similar rates. But when you look at our program, and we initiated our program during the same time period, our retention rates were 86%. It's an astounding number. We actually ran it 3 tests, we didn't believe it. And this is somewhat preliminary data that we're kind of trying to look further into now. But this speaks to the importance of transition education and why it's important to have the education to have patients retained in care. Because sometimes they don't even know that they still need care. And some of these things are discussed or retained or whatever. But if you hear it over and over and over at each cardiology visit, they also build a rapport with the transition team. So they trust the transition team, right? And so for the programs that don't have anything to help them, I am now working on this project here. I just finished a K award for this project to build a mobile application that is modeled entirely after our in-person program to give individualized learning to patients with congenital heart disease. You can see there that I gave myself CCTGA. This was my profile. And you can see we have before and after pictures of what the disease looked like initially and then what it looks like after surgery. Then we have various modules in the app, including the learning, the checklist, the profile, questions. We partnered with the ACHA, the Adult Congenital Heart Association, to then have them be able to do peer-to-peer mentoring. Because a lot of our teenagers said, I need to talk to someone who's like me, there's no one like me in this world. I'm like, yes, actually there is. And so they don't know that though. So partnering with the ACHA was pretty critical to this process. Okay, so last thing is some DEI applications. So have you guys ever seen Nailed It?
Mm-hmm.
Right? That's a lot of DEI QI applications, right? So everyone has these aspirations of what DEI, quality improvement DEI looks like, and then it ends up looking something like this. And so when we talk about using QI to improve DEI initiatives, we can talk about what things look like in pediatric cardiology. So what does DEI improvement look like in pediatric cardiology as it pertains to women and underrepresented minorities in our field? Well, this is a abstract that came out in March of 2020 at the ACC, looking at representation of women and minorities across academic pediatric cardiology programs. And what they found is that we have done better in terms of getting women in at the lower level in terms of fellowship. 55% of fellows are women now, which is pretty amazing. But as you go higher and higher and higher on the academic chain, you see that division chiefs only make up 17% of women make up division chiefs, despite the fact that we make up a much higher percentage of the workforce. If you look at underrepresented minorities in pediatric cardiology, we're doing a little bit better with the fellows, but of course, we're still in single digits in their faculty. And so a lot of work is to be done there as well. And so if you're looking at ways to address workforce diversity from an equality improvement framework, it's clear that organizational leaders have to then make the pursuit of diversity a shared responsibility that extends down the chain of command. So it has to start at the top. It has to be a priority from the top. And this is similar to what we saw in terms of crossing the quality chasm that publication I found earlier. And that these data should be used to catalyze action in terms of workforce diversity measures and including measures that are related to structure, process, and outcomes for DEI should be tied to executive evaluation and compensation. So it can't just be, that's nice. It has to be bigger. We can actually do this for fellowship as well. So these brilliant people did a study in 2021 saying how can we increase representation of women and minorities in the space of adult cardiology. 20% of adult cardiologists are women. So they have a much harder time there. And so they redid their entire fellowship recruitment. They got a whole DEI task force. They changed how they screened patients, how they interviewed, how they ranked applicants, and then the post-match interventions. And their outcomes were astounding. So you can see there on the we're going to focus on the general cardiology fellows and row E there. You can see that there is pre-intervention in the darker colors and post-intervention in the lighter colors. On the x-axis is the year, and the y-axis is the percentage of individuals. And you can see that they were able to increase women in their fellowship program from 27% to 54% after 3 years of their interventions. And underrepresented minorities, they were able to increase from 5% to 33%. Really not trivial numbers. This is a dedicated group of individuals. And so overall, they went from 27% of women and minorities to 66%. Not trivial in terms of their fellows. Again, this was a QI initiative, not PSA cycles, not key driver diagrams, any of that stuff, right? And so applying institutional quality metrics then to diversify leadership and mission and goals of the institution is going to be really important for the minority medical pipeline and the retention of the faculty. And then we talked about QI metrics for DEI training. We talked about implicit bias training and microaggression training and cultural sensitivity and humility training. And applying QI metrics to improve patient care to ensure appropriate services for parents, language services, and of course social determinants of health screening. These are all QI initiatives. These all don't require a degree in QI. These are all things that you can actually do on the daily to improve outcomes for our patients. If you have not read this, please read this. This is a publication recognizing and reacting to microaggressions in medicine and surgery. It is critical to understand that there are at least 4 different types of microaggressions. And, in the interest of time, I can't get into this, but suffice it to say that there are at least 4 different types of microaggressions. And it's interesting because as I walked along this hallway into this room, I saw one of them, which is the environmental microaggressions, which is workplace reflections of microaggressions. So everyone that's hanging in that hallway are older white men, right? How many women in the room have noticed this? Right? Okay. No offense, guys. I'm just asking.
How many men in the room?
How many men in the room have noticed this?
That's a good.
I came up the back door.
Such a cop-out.
That's so much.
And so there are different types of microaggressions, and it's important to look at all of those types of microaggressions and understand what they are and why they are arguably more important to recognize than implicit bias. Implicit bias is also very important, but these microaggressions are important not only how we interact with each other, but also how we interact with our patients. All right, systemic level, targeting diversity, inclusion, equity, and belonging, diversifying our fields. That includes subspecialties. Every time a minority enters medicine, they're told, oh my God, we are so glad you're here, and we're so glad you're gonna be a general family practitioner. We're so glad you're gonna be a general internist, a general pediatrician. And they are never encouraged to go into subspecialties because you have to go back and serve your community. Well, there are different ways to serve your community, and you can be a subspecialist because we need people of color in subspecialty work as well. Diversifying journal editors in academic societies. Who is deciding what gets published? Who is deciding who speaks at meetings? Who is deciding who sets the agenda for these meetings? And what makes that important? Improving the pipeline, we talked about ACHD care, and of course transition and transfer. So we're now kind of working on initiatives to figure out how you can engage subspecialists in the pursuit of health equity. I was able to write this piece with Dr. Elena Fuentes Affleck. She's a brilliant dean of medicine, pediatric medicine at UCSF. And we gave examples of how you can do this in terms of health equity training for subspecialists, in terms of research, scholarship, and funding and dissemination for subspecialists. And we also talked about workforce diversity in that publication. So the last thing I really want to hit here, because everyone shuns this, is social media. Everyone's taught, please don't put anything on social media, it'll follow you and it's evil. And so that can be true, depending on what you place in social media. However, social media can be used as a tool to reduce inequities. And so this publication came out in 2021 from JAMA. You all know that JAMA is very high impact. And so this was a podcast that these two individuals were speaking on. They said, well, there's no such thing as a racist physician, so how can they do structural racism in healthcare? First of all, yeah, what? Yeah, exactly. This JAMA put out this publication, and so you have to ask yourself, who in the world allowed this to occur when they clearly don't understand the term structural racism, right? And so this blew up on Twitter because people said, what in the world is JAMA doing? This is crazy. And so because of this blowing up on Twitter, it really blew up on Twitter, and then people started writing JAMA that you need to do better, you need to remediate these people who had these publications, who had this podcast. And sure enough, this JAMA editor was put on leave as a result of this reaction on Twitter, and actually ended up being fired as a result of it. To the credit of JAMA, they said, apparently we need help. We are now looking for an editorial director at JAMA. And good for them, because this is something that needed to be done, and they recognized it, and they're now doing something about it, but this would not have happened were it not for the outbursts on social media. So it can be used as a tool. This last one affects cardiologists. So this is an individual from Pittsburgh who put out a publication on diversity, inclusion, and equity, the evolution of race and ethnicity considerations for the cardiology workforce in the United States. And basically, this paper came out during the pandemic, came out in March of 2020. So people did not actually, it kind of flew under the radar, but it went through peer review, editorial review, all of the reviews. And it was put out in the Journal of the American Heart Association. And it basically said that if Blacks and Latinos are allowed to be cardiologists, that they are underqualified to be cardiologists because they were admitted to medicine through affirmative action. And because of that, they are actually going to be harming cardiology patients. So they should not be allowed to be cardiologists. That blew up on Twitter also, and some people said, what is happening? Hey, American Heart Association, are you serious? How do you even call this research? This is someone's opinion, and you're couching it in research. This is not research, this is somebody's opinion. And people were really, how does it happen? How did it go through the peer review process? How was this published? And so the American Heart Association said, what? We don't know where this came from. We don't agree. And everyone said, that's really great. Retract the paper. And they did. And so, speaking to the power of social media, this again would not have happened were it not for the pressure on social media. And so, just speaking to all of the different QI opportunities that you have, if it doesn't have to be super science and QI stuff. You can do stuff like this every day to bring awareness to things that maybe need to be researched more, or to how do we deliver QI initiatives. And there are lots of places to find QI opportunities in cardiology, tons. We have all of these groups, the ACPC, the SOCCS, CHPHC, NPCQIC, PHN, Cardiac Networks United, all these parent care groups, lots of places where a lot of advocacy work and QI work is being done. And so I am happy to take any questions.
Thank you very much for another wonderful and inspiring talk. Questions? Eric?
Yeah, these have been fantastic talks, so thank you so much. This is something I've been thinking about for a long time. Because race is a social construct, when we do research on whatever diseases or drugs or whatever, and we look at race as an indicator, and then we report that, if we don't report a lot of the other social determinants of health, are we perpetuating this myth that there's this biological difference? And how do you do that if you don't have the ability to look at some of the other social determinants? Should we continue to look at this kind of construct, whether it's actually true, knowing that a lot of people that read the report may see it in a biological sense instead of in the social construct that it really is?
Before you answer, were the people on the WebEx able to hear the question? Yes.
I don't want to repeat it.
Turn on your phone. Oh, I tried that. Oh, there we go. Yeah. So I don't want to send the message that investigating outcomes that are differential by race is not important. It is important. And so you have to look at that and say, okay, well, there are differences, but you cannot say there are differences based on race, the end.
Right.
Because that is the thing that perpetuates, oh, well, it's biological. And so I think we've learned a lot of things in adult medicine. Adult medicine has said, they used to actually, they still do, they're rectifying this now, but they used to say, oh, your GFR looks like this if you're black, like this if you're white,
Right.
right?
That's
So they were doing race adjustments
Exactly. Yeah.
for GFR.
Right.
And there's several things that there were. I had no idea how many things there were for race adjustments. PFTs
Yeah.
have race
Exactly.
adjustments too, which matters for our patients, right? And so if you're looking at what it means in terms of interpretation of data, this is why it is critical to at a minimum, to at least include some social determinants. Maybe we don't have all of the social determinants, maybe you don't have neighborhood level data and, in a granular fashion about what the air quality is like for these people, no. But if you have something as simple as their insurance status, you know that if you're a Medicaid patient, chances are you have a low socioeconomic status, right? So you can at least make that association. I don't even think you make a causation, you can make an association, because those things tend to run with patients who are Black and Latino or Native American because of the systemic racism that disenfranchises populations, right?
Yeah.
And so if you're going to, doing it is not wrong, but it's not great to do it without having some other contextual explanation for these associations. Because if it's just an association, you say, oh, it's because they're Black, then comes the biological, it's because they're Black and it must be a different biology. No, it's because of what happened in this country to these populations. And so it doesn't have to be super granular, but even something as primary language, we can get that pretty easily off of our electronic medical records, right? We're looking at differences based on, like I said, insurance status. Sometimes we will use primary household, like you have one parent or two parents, things like this, things that would make it more challenging for you to be able to access care.
Yeah, two questions. One is that just on the dovetailing on that line, what factors have you seen in EPIC that you can then use as some of those markers? That's the first question then, if there's one.
Well, so insurance is the easiest, lowest hanging fruit, and again, it's not perfect, because you have primary insurance and secondary insurance,
Right.
it's not perfect. But typically, I think if you look at the primary insurance, that is helpful.
Yeah.
But they also have language fields in Epic. It turns out, it's kind of annoying because they have two language fields. They have one for child and one for parent, which is kind of like, all right. And so sometimes depending on which one you use, they will have a one language for the child, English, and then one language for the parent, Spanish, which is unhelpful. But in the data that we've done, looking at this, we default into the parent language to say, okay, if the parent doesn't speak their English as their primary language, that may be more challenging for them to communicate. It doesn't necessarily mean that they're lower SES, but it makes it maybe more challenging for them to communicate, right? Zip code is another one, and of course that is going to now require IRB approval, right? And that's not necessarily de-identified as much. So zip code, if you can get zip code level data, there's a new tool that a lot of cardiologists are now using that's called the DeGauss tool, right? That's able to get data from various institutions that you put zip code level data into, and then it ends up being hidden, de-identified, so that you can report your outcomes based on zip code level data without it actually being revealing of who lives where. And so it's this very specific tool, it's the DeGauss tool, it's a very specific tool that cardiologists are now using to do multi-institutional studies while it ends up blinding them. It ends up giving you the results while blinding actually the patients that self-protect their identity. And so those are some of the main ones that we use, I would say, not perfect,
Yeah,
but
I was
just
just,
something.
if you follow up on, if you find other things that sort of the usual. The second question I had was related to the transition program. Retention, what was the definition of retention and under what age range, or how did you define that?
So the definition of retention was still being seen, having been seen by a cardiologist in our system after leaving after being outside of the pediatric age range, so 18 and above.
Okay, so that was retention after transitioning, so post-transition, in theory.
In theory,
Okay.
yeah. And so, and then again, it was only patients who were still being seen at these children's, right?
Okay.
And so we don't have data on those that left or those who went to other places, so I the big caveat in that is like, I guess it's possible that many more patients stayed in the last 4 years in the main campus and not in satellite campuses. I guess that's theoretically possible. It seems unlikely that it would be that disparate for the population that's living in the Houston area.
I'm Mike Powers, I'm a pulmonologist, so I'm a unicorn in this room, but I do QI work. A question for the
Oh God, you're like,
cardiologist.
I'm so offended.
No, but I teach the head and the heart, so data and the heart in your work. So how involved are we in the QPC network here? Because I know I'm involved a lot with the learning networks through the Anderson Center at Cincinnati. And, equity has been a real focus on all the networks, and all the networks are talking to each other the last 2 or 3 years. I mean, that is a fruitful place if you want to do quality improvement around equity efforts. I mean, you'll have resources and spread and networking. So how involved are we in that? Is that an opportunity?
And I failed to mention Pact 3 and PC4.
Yes,
There's
yeah.
other ones,
Mhm.
but.
So elaborate a little bit, QPC.
Yeah, how involved is our cardiology group in those networks in terms of
Okay.
utilizing them as a resource of support and education and networking?
Yeah. Good question. So we're a member institution in PCQIC, we're a member institution PC4, and then obviously a few other registries, but those two are probably the ones that we ping the most often. Monique is our interstage champion and director, so she gets board at PCQIC. PC4 in particular, we're finding extremely helpful because it's essentially real-time output of your data. You add your data and then you can query it at any time, whereas some of our surgical database like STS, we have to wait until they output their data, and there's some commentary on whether we're really able to glean what they say they tell us. But those two are particularly helpful. And
I guess my question more is the way like the social determinants of health, a lot of networks are working on that. Can you bring that back to your group and work on social determinants of health, or race, and we're working on confirming it's all self-identified race and language data in our database right now. So that's a current QI project.
Yeah.
But it takes infrastructure like their transition team. So we have social workers, dietitians asking these questions. It's a team approach.
Yeah, I can't tell you the number of patients that have applied to Latino and they're Filipino.
Exactly. So, exactly.
Yeah, I don't know if to what, and then the answer to what degree NPCQIC incorporates that in their approach and the data that we're getting from them in their current research
I can ask,
projects.
because I meet monthly with the leaders group, so I can ask them.
I know that for NPC QIC, it's a major initiative, doing equity work is a major initiative for them right now. They're trying to figure out which direction to move in,
Yeah.
but it is a major initiative. My biggest concern from a QI perspective in these spaces, and especially spaces, is that, as we discussed previously, people said, oh, I see, outcomes are differential based on race, so it's a biologic problem. Thanks. And now we're like, no, actually, it's due to, largely in part due to social determinants of health. So I'm concerned that we're moving towards a description of outcomes based only on race to a description of outcomes based on social determinants, but no one's doing interventions.
Right.
That's the biggest
Yeah.
concern, right? And that requires funding. That requires people to actually buy into the notion that interventions can make a difference, which is why the person I brought up this morning, Dr. Kira Bona, the hematologist and oncologist from Boston Children's, did a brilliant move. She said, okay, that's cool. I'm just gonna embed these social determinants of health interventions in existing randomized controlled trials and to see if the intervention themselves on the social determinants make an impact in the outcomes. Because I'm not changing the trial. I'm just gonna now embed an additional factor of giving the transportation to get to the hospital.
And then separate later.
Well, they separate them by kind of, it's randomized, so it's like who gets help, who doesn't. But who gets transportation, who gets food, assistance with food, and that's how she put it. So she doesn't change what they're getting. She just now adds an additional arm of doing interventions on the social determinants. And, God bless the cancer people, they have way more money than we do, let's be honest. They have way more funding than we do. And so it's challenging. They have a lot more time than we do to do research. And so it's a different space than the one that we're in, but it matters for our people too.
Yeah, one of the case reports that you guys weren't in, but I came late to the patient whose mother was illiterate in Spanish speaking only, as well as English. When I sent them to make a wish, and she got what her wish choice was, the child's wish choice was an Apple cell phone plus a payment plan for like 4 years, and that actually changed to be able to like really use my chart because she was English, and I had no idea that intervention was like an actual intervention per se. I thought it was going to be something great for the kid, but she was pretty smart and used it in a way to advance her
Awesome.
own healthcare and advocacy, which was amazing.
Amazing.
Yeah.
That's why we're talking about, if you build it, they will come,
Yeah.
but they know how to get there.
Mhm.
That's key.
It's interesting you say that because the other patient that we presented, he got a Make-A-Wish. He went to Walmart and he bought all his family clothes.
Oh, that's right.
Clothes and food for his family, and he got himself like one toy, I think.
I mean, seriously.
Yeah.
Super amazing.
But you can look at the difference they made with the food insecurity. Right?
Yeah.
So I mean, we screen for food insecurity, and the main intervention is education about the resources that are all available. And the second intervention is we do have financial resources that, because of philanthropic contributions, we're able to band-aid a little bit, but it's the systemic, what I learned is we have to partner more with the community.
Mhm.
That's what I learned,
It's key.
right?
I mean, it's amazing how many resources you have. There's actually an index that you can look up. Oh my God, what's the name of this thing? It's an index that you can look at in neighborhoods across America that tell you all of the community partners that you can work with to address social determinants. And of course, now I see this really cool thing with no name.
Is it on Bertha?
It's not. On Bertha is great too, but it's another one where you type in your zip code and it shows you all the resources. And I'm blanking on the name of the
You can dial it in locally too. Our social workers worked on this. There's about 30 different resources. They dial it in per county in the state of Oregon. So maybe I can have them share it with you guys.
Who screens for you, Mike? Is it the social workers and the CF program?
When it was in person, it was the dietitian that would screen, and then the social worker would do the intervention. When we went to virtual, we switched all to social workers. But that's, so I don't know what you guys have a clinic. Does the social worker see every patient? Probably not.
Yeah, it's like you're ready to go.
Unfortunately.
But they should, right?
Yes.
Because 85% of the health outcome is not what we're doing here at Dornbecker.
Yep.
Any questions from our audience online? Either in the chat or if you unmute yourself. I have one more question. You know, there's a lot of trainees here. Your line of research is relatively different from the research that many other people do. You have a master's in public health. Is that the entry into this line of research, or how does one build a career in this population-based research that you do?
I want to be clear that my degree in public health is in policy. So we do not get a lot of stats training in policy. And so it's, while it was helpful, I got a little bit of stats training, so I kind of know enough to know what I don't know, or at least then. But the real key to doing this kind of work is collaboration. That's the real key. And even as a fellow, I was telling the fellows today that my first project as a fellow was, again, based on my own noticing. So I guess part of the answer to doing this kind of work is you just noticing stuff. So we actually had a joke at Texas Children's of every time there was a heterotaxi patient that came, which we all know have had these pretty unfortunate outcomes, it was always a Hernandez, Rodriguez, Lopez from the Valley, always. They were always from the Valley, which is the Texas-Mexico border, and they were always Latino. Yeah. And so it was actually kind of a joke. It was like, oh yes, there's another heterotaxi. Is it a Garcia from the Valley? And I was kind of like, why are we not worried about this? Like, how come I'm the only one who's kind of like, this is not cool? Like, why? And so I partnered with the Texas Birth Defects Registry, who again, brilliant epidemiologists who are actually paid to do this work. I don't have to pay them anything. I'm like, cool. But I have the expertise in knowing what a heterotaxi is. So they have these databases of these, and I can look at all of their data. It's an active birth surveillance registry. So I can look at all of the data, as long as they have an IRB with them and us, to see who constitutes, they have all of they have clinic notes, they have imaging, they have cardiology notes, etc. So I knew who had heterotaxy, I could identify it, and then looked at outcomes. And so prior to this work, the population that was described as having heterotaxy more than any other group were Asian. And I was like, really? Where? Like, I know that I live in Texas, we have a lot of Asian in Texas too. But I was kind of like, I don't see that at all. So I started asking my friends around the country, hey, when you have a heterotaxi, what do you see? They were like, they're usually Latino. I was like, well, you too? Okay, Michigan. So you know, it was concerning enough that I started wondering if there was a cluster. So the way that I got the birth defects registry, which is again it's an entity of the CDC involved, was I said, you know, you guys described a cluster of anencephaly in the same area back in the 1990s. I think there might be a cluster of heterotaxy, and they were like, what? A cluster? And so that's how we got to work. That's how we got to look at the work. And I did it for free as a fellow to be able to look at this work, and then we were the first people to describe that the predominance of heterotaxy in Texas, all across Texas, which is lots of different individuals, was actually Latino. 70% of heterotaxy were Latino, and the reason that we had more than that Texas Children's was because of referral lines. There was not a cluster. It was because if your cousin's cousin's cousin had it, and somebody knew, I heard, hey, by the way, I heard they take care of these people in Texas Children's. That's why we have so many from that area, because several of them can talk to each other and you know, in social media stuff. And that's how we have these groups there. But my point is, like, if we had not had you know, collaborative work with those people, I can't do this work without them. I can't do this work without epidemiologists, without sociologists, and that, because they have expertise that I don't have. I might know about the medical stuff, but they know about the other stuff. And together, I think we're able to have a policy lens to be able to move this forward. It does not require a degree.
Yeah.
It requires collaboration, creativity.
And by the way, there is a lot. There are a lot of very smart people in those domains here, which is you that you know, we can partner with. They do exist. All right. If there's no further questions, I think we'll call this to a close. There is one question that's popped in. Excellent afternoon lecture, eye-opening and inspiring. Thank you so much. I would echo that. No further comments, and thank you very much.
Thank you.
Thank you. Well, I wanted to thank Ashley for putting this together today.
Yes.
Yeah.